Good evening, everybody, and welcome. I'm Alison Button-Sloan. I'm the Advocacy and Community Engagement Coordinator for Melanoma Patients Australia. First, I would like to acknowledge the traditional owners of the land upon which we meet today, their elders past and present, and those emerging. It's wonderful to be here tonight and to be holding our very first webinar of our Melanoma Symposium series. We have over 260 people attending tonight from across Australia, which is just amazing. And I thank you all very much for coming along. Tonight, we have 3 presentations from our CEO, MPA CEO, and of course our 2 guest speakers, who I'm sure you'll find very interesting and informative. So now first is some housekeeping. We will be recording this video, this webinar rather, and it will be available on our website in a week or 2. Now at the bottom of your screens, you will find the Q&A function, which will give you the opportunity to ask questions anonymously, and we'll do our best to answer as many as we can. So our next speaker is Victoria Beadle. And I'd like to introduce Victoria. She's MPA's CEO, and she's here to give you an overview of our services as well as the organisation, of course. Thank you, Victoria.
Thank you, Alison. And it's a great introduction, and good evening, everyone. A very warm welcome to webinar 1 of a very special 4-part webinar series designed by melanoma patients and carers for melanoma patients and carers. I'd like to start by acknowledging our supporters that have helped make this evening possible: Melanoma Institute Australia and Bristol Myers Squibb. Both organisations understand the importance of ensuring melanoma patients and carers have access to high quality information and support. I would also like to thank our wonderful keynote speakers, Associate Professors Ma and Gyorki, for sharing their knowledge with us this evening. 2020 has certainly thrown us all some curveballs, and for many of us, our entire world has changed. Many of our routines are gone. Many are working at home while juggling family commitments. There is real fear about COVID-19 and the impact it is having on all of our lives, our systems, health, finances. Add to this a diagnosis of melanoma, and we know that many people are really doing it tough. So thank you this evening for giving up your time to join us for this special seminar. Melanoma Patients Australia is an independent national charity. We connect, support, and advocate for Australians affected by melanoma. During this difficult time, our team has worked really hard to adopt and enhance our vital support services and found new ways, like tonight's webinar symposium. In order to provide the best possible support to you, our amazing and diverse community of melanoma carers and patients, we're working to ensure that no one affected by melanoma walks alone. We do this all with no government funding, and we rely heavily on our supporters and wonderful volunteers across the country. During this time, our work to support and advocate for patients and their families has never been more needed. With more people missing vital health checks due to COVID-19, our role in raising awareness of the dangers of the sun and encouraging people to prioritise their skin and their melanoma surveillance checks is critical. Here at MPA, we offer a wide range of support services, such as the National Melanoma Support Line and a range of support groups in varying formats across Australia. In response to the COVID-19 pandemic, our face-to-face support groups have moved to be virtual support groups, making them safe and accessible for many patients and carers. Demand for our digital support activities has continued to grow. Our closed Facebook support group has risen from 182 participants in 2016 to over 1,800 active and engaged patients and carers providing peer support to each other in this unique environment, which is facilitated by MPA. We continue to deliver our National Telephone Support Group in partnership with Cancer Council New South Wales for people with metastatic melanoma. It attracts participants from across Australia. I'm also excited to advise you of a brand new service which we launched last week, the new Telehealth Melanoma Nurse Program, which has been generously funded by Melanoma Institute Australia. The Specialist Melanoma Nurse Service will support patients in navigating the health system, accessing available services and making decisions regarding their health. This personalised support service is available to all melanoma patients and their carers. MPA represents Australia on a global level through the Global Coalition of Patient Advocacy and collaborates on a national level with a wide range of groups. MPA remains a trusted advisor on many national boards and panels where we engage with researchers, clinicians, government, industry, and other charities and organisations with similar objectives. We continue to fight hard and advocate for melanoma patients and their families on a range of important issues, such as equitable access to new and emerging melanoma treatments. We've also played a key role in advising the Department of Health on ways that consumer views can and should play a more vital role in decision processes, such as the Pharmaceutical Benefits Advisory Committee. We've actively surveyed thousands of consumers regarding their views and thoughts on whether new, potentially life-saving or life-prolonging treatments should be made available at subsidised rates in Australia. We've also actively raised awareness and encouraged consumers of their rights to have a say and get involved. I've personally reviewed these submissions, talked to many consumers and cried many tears after hearing some of the tragic stories where the drugs have arrived too late to save a life. Many who've had to face the heartbreaking decision as to whether to sell their family home, and many faced with shocking financial hardship. A number of the treatments that we've advocated for have been listed on the PBS, and a number have been recommended for listing. However, there remains a great deal of work to do to ensure patients get timely access and have the best possible treatment options available to them as they emerge. At Melanoma Patients Australia, we've been working for 14 years towards preventing melanoma and to supporting Australians affected by it. But we know there is still a lot of work to do. That's why in May this year, we started a new campaign called the Melanoma Movement, an easy way for all Australians to play a part in taking a stand against melanoma. We have a wealth of great resources on our website that you can download and use to raise awareness of melanoma in your local community with friends and family. They focus on the importance of regular skin checks and prevention. We're also looking for people interested in making a difference, and I would encourage you strongly to look at joining MPA's Melanoma Advocate Program. MPA needs passionate melanoma advocates to do a range of roles, such as become local media spokespeople, speakers at our events, advocates with local politicians. We're always looking for consumers to help us to input on critical research projects, completing surveys, and providing feedback on the issues that matter most to you. We'd love you to get involved with us. If you are interested in finding out more about any of Melanoma Patients Australia's activities and services, then please reach out to us. We'd love to hear from you. You can check our website, shown here, melanomapatients.org.au. It has a wealth of high quality and evidence-based information available, and all the ways that you can access these services and get involved in our important work. Thank you, and I really hope you enjoy this evening and the wonderful keynote presentations from our clinicians. Thank you so much for joining us this evening.
Thank you, Victoria. So our first guest speaker this evening is Associate Professor Victoria Ma. And I'd just like to say a few things about Victoria's professional background. Victoria is a fellow of the Australasian College of Dermatologists and the director of the Victorian Melanoma Service at the Alfred Hospital. She is a NHMRC Early Career Fellow at the School of Public Health and Preventative Medicine at Monash University. She completed her PhD at Monash University and Peter MacCallum, entitled Clinical and Molecular Characteristics of Aggressive Melanoma. Victoria is a board member of the Skin Health Institute and the Melanoma and Skin Cancer Trials Group, where she is involved in a number of investigator-led trials. She has authored and co-authored a number of chapters for the Cancer Council Australia Melanoma Guidelines and is the clinical lead for the Melanoma Clinical Outcomes Registry. Thank you, Victoria.
Just getting set up. Thanks so much, Alison and Victoria. That was a wonderful overview of the fantastic work that is being done by MPA in advocacy and prevention and so much more. So I think our patients are very lucky to have you, and thank you for inviting me to speak today in the first of a number of sessions that are a great initiative to get some fantastic information out to where it's needed. So this first session, I'm going to, as a dermatologist, obviously focus on dermatology, and then David will speak following me with more of a focus on surgery and staging. So I'm going to cover what you need to know about skin checks and what you should expect when you go and see your GP or your dermatologist for a skin check, and what to expect during your surveillance checks, how we actually diagnose melanoma, and then I'll touch a little bit on wound and scar management, and then I'll talk about referrals and multidisciplinary care. We'll talk a little bit about the impact of COVID as well, although perhaps a lot of you are sick of hearing too much about it. So I think everybody on this webinar can understand the challenge of melanoma. It is unfortunately Australia's cancer. It is a big issue for us here in Australia. Unfortunately, we lead the world in our incidence rates of melanoma. And here it's the third most common cancer for men after prostate and bowel, and for women after breast and bowel. And that's actually invasive cases of melanoma. But if we count in situ cases of melanoma, then it's certainly the most common cancer in Australia. It's the most common cancer in young people, so it does affect young people, and it gets more common with age. So certainly increasing age is a risk factor because we accumulate a lot of UV damage over our lifetimes. It's a costly cancer to the health system, and oftentimes because of the number of biopsies that we take as a just in case to make sure that we're not missing anything. So that's an issue as well. It costs skin cancer in general, so that's basal and squamous cell cancers, as well as melanoma, costs the health system about close to $1 billion per annum. And melanoma is a fraction of that. There's no population-based screening program in Australia, and that's really because there's no evidence that a population-based screening program will really reduce melanoma mortality. Just because there's a lack of evidence doesn't mean that there isn't benefit from a more targeted screening program, and so there is a lot of evidence, a lot of input at the moment into trying to develop something that is a little bit more targeted and will be effective. Because at the moment we have screening, our screening is opportunistic. So when you see the GP is often an opportunity to do a skin check at the moment, but there's nothing that is like the breast or bowel cancer screening programs. So surveillance strategies and frequency of visits really does vary between practitioners, and the advice varies. And diagnostic accuracy varies as well. So you can imagine if you see someone who's experienced and seeing a lot of melanomas every day, then their accuracy will be quite good. And if you see someone who is not so experienced in treating melanoma, then they may take a number of biopsies for any one melanoma that is diagnosed. So who detects melanoma? Well, actually most melanomas are self-detected. So that's why it's really important to understand what's on your skin, to know what's on your skin, to check it yourself at home and take note if there are any new lesions or any changing lesions. 10 to 15% of melanomas are actually diagnosed by your partner or significant other. Wives are quite likely to detect, and often we hear that my wife wanted me to come in and get it checked. And only 15 to 20% are actually detected by doctors during a routine skin examination as an incidental finding, although when they are detected in that way, they tend to be thinner. So who should be having a regular skin check and how often? Well, we get asked this a lot, and it really depends on the individual's level of risk. So if you're low risk, then it is quite safe and acceptable to be checking your skin at home, and we suggest that you check your skin at the change of each season. If you are slightly higher risk, it is good to have those opportunistic checks if you're going to the GP for other reasons or booking in specifically to have your skin check. If you're higher risk, we do suggest more frequent surveillance. And if you're ultra high risk, and we'll go into what that means, then it is a good idea to see a dermatologist for surveillance. It may be a good idea to have photography, and we'll discuss why that might be useful, and check slightly more frequently, and particularly if you've got a lot of moles, if you've got other risk factors. So what are the risk factors? Who's at high risk? Well, there are a number of risk factors listed there, and certainly if you've had a history of melanoma, you're at an increased risk of developing a second melanoma. You've essentially proven that you can grow them. You may get a second or third in your lifetime. So if you've had a past history of one, you have approximately 10% risk of getting another. And if you've got a lot of other risk factors, you may have 10 to 20% risk of having another melanoma. Having a large number of moles is certainly a strong risk factor, and there are the larger moles that you can see in this example here, which are called dysplastic moles, and they increase your risk as well. We don't recommend routine excision of dysplastic moles or moles as a just-in-case strategy, because removing those really doesn't reduce your risk. Most melanomas actually arise as a completely new lesion rather than a change in a pre-existing mole. So there are a number of algorithms that you can use to work out your own risk. We developed a risk calculator which is available on our website. There's also one that was developed by the Queensland group, and a more recent one on the Melanoma Institute website, all available. So you can have a look at those and look at your own risk. And that's an important thing to know. So when we think about melanomas, there are certainly different subtypes, and you will have heard probably about some of the different subtypes. The most common by far is a superficial spreading melanoma, and that usually occurs on the trunk in men, on the lower leg in women, and it is associated with people with a number of moles. Lentigo malignant melanomas are common on the head and neck, and acrolentiginous melanoma on the feet. And they're all examples of what we call radial growth phase melanomas. So they tend to grow along the epidermis, which is the superficial layer of the skin, for some time, usually months, before they start to invade and become more concerning. And then there are vertical growth phase tumours, and they tend to sometimes skip this radial growth phase of being confined to the epidermis only and can invade more rapidly into the dermis and the deeper layers. And they are nodular melanomas and desmoplastic melanomas typically. So I explain that just because it does point to some of the challenges that we have for screening and early diagnosis. So you can imagine that the growth rate of the melanoma is important in how easily we might be able to detect it at an early stage. So those vertical growth stage tumours actually have a very narrow window of opportunity to detect when they're still thin. And nodular melanomas, we've shown, have an increased growth rate, being a vertical growth before that as a first pattern of growth, rather than that more prolonged radial growth phase to start with, which is what we see usually with superficial spreading. The other challenge that we have is diagnostic accuracy, and some melanomas can present in quite an atypical sort of way. And this can lead to either patients not realising that it's something that could be a melanoma because it just doesn't look like, you know, the pictures that you would see, or doctor delay because doctors don't recognise that it is something that needs more urgent attention. So what should you expect when you go for a skin check? And really, because of the features that I've just discussed, the history is really important. So if it's something that you've noticed that is growing and changing, usually over a period of about a month, then that's something that you should be getting checked, and your doctor should take notice that it's something that you're concerned about because it's new or because it's changing. You should expect to have a full skin examination. So that means that really you need to expose all of the skin down to your underwear so that we can examine all of the skin surface. Usually we'd start from the top and work down, so go through the scalp, look at all of the skin, including between the toes, and make sure that we've seen everything. If there's something that you feel your doctor hasn't seen, it's a good idea to stop them and say, did you check this area? It's always fine to do that, and we encourage you to. Usually when we're doing a skin examination, we will use dermoscopy, which is a light, and you can see it in the photo there of my colleagues using a dermoscope to check a mole. And that just magnifies the lesion and lets us see some of the structures within the skin. And really we're looking for certain patterns that make us think that it is either a sinister lesion that needs further attention or that it's benign. If you've had melanoma, if you've had invasive melanoma, you should expect to have your lymph nodes felt. Make sure that there's nothing of concern, and to check the scars and make sure there's no evidence of any pigmentation coming back around the scar or any lumps under the skin in that area as well. So we look, as I say, with a dermoscope for certain patterns that we see, and we go by the A, B, C, D, E rule for a majority of melanomas, and you can see that in these lesions there's some asymmetry, there's some border irregularity, colour variation, and some, but not all, have a larger diameter. So we can be fooled. Sometimes melanomas can be small, and we like to catch them when they're small. And the E for evolving is important. So anything that's changing and growing. But of course, there are difficult cases. So these are the ones that can fool us. There's the ugly ducklings which stand out, and that makes things easier. But there are other lesions that can mimic certainly other benign conditions and can look just atypical for what we might consider to be a usual melanoma. Lesions in the scalp can be particularly difficult, and if they lack colour, they can be particularly difficult as well. So that's where the history is really important. Acrolentiginous melanomas can certainly mimic other more benign conditions like warts and so on, and you can see why that could be confusing. They can also be mistaken for pressure sores, and nail changes can be mistaken as well for other benign conditions of the nail. So it's not always easy. Sometimes when we're doing a skin check, we will find something that is concerning, and so we'll recommend a biopsy. And if it's something that we're concerned is a melanoma, the usual practice is to excise it with a narrow margin to start with to make a diagnosis. And depending on the site, it might not be possible to remove the entire lesion, particularly if it's a big lesion or if it's in a cosmetically sensitive area or difficult area like the nail or the foot to biopsy. And so punch biopsies are occasionally used, and shave biopsies might be used for particularly in situ lesions, for instance, lentigo maligna on the face. So how do we care for our wounds? Well, it's really important to take care of yourself. So no going out for a lot of exercise after you've had your surgery. It's best not to try to be too active or run a marathon immediately afterwards. Best to elevate the limb if you can. So if it's on your leg, you can put your feet up. You have the night off, no dishes, rest and get some help, ask for some help around the house. After removal of sutures, it's important to know that the scar will not be as strong as normal skin. So you still need to be a little bit careful of it. So particularly if it's on your back or somewhere that stretches easily when you're bending over and so on, you just need to be a little bit careful that you're not putting too much tension on the wound. Scars will mature over months and usually improve with appearance over a number of months. And so really time is your friend when it comes to maturing of the scar and so on. And sometimes we'll recommend covering the scar over with micropore tape, which is like a paper tape that just helps with the scar maturing and covers it nicely as well. Some areas are particularly prone to hypertrophic scars or keloid scars, and some people are a little bit more prone, some skin types are a little bit more prone to these. And hypertrophic scars are really just slightly raised scars with keloid scars where the scar grows beyond the scar itself and can be a little bit more difficult. And there are tricks that we have for these, but the most important thing is to have your melanoma removed and take care of that. And then down the track, after giving it some time, we can discuss how to improve the appearance if that's an issue for you. There are other things that we can use that don't necessarily require biopsy to look into the skin, into the layers of the skin. We do sometimes use confocal microscopy just to map lesions, usually after a diagnostic biopsy has been taken, but sometimes to reassure us with the appearance of something, particularly in a cosmetically sensitive area, that it doesn't require a biopsy. And this is an adjunct to dermoscopy, but it isn't widely available. It's really something that's available in the tertiary setting. So should I have photographs? Well, there are different photographs that are available, and so it's important to understand what we mean when we say photographs. There's total body photography, which essentially takes an image of all of the skin surface. And then there is sequential dermoscopy, where we take close-up images of individual moles, and that's usually done to monitor them over time and look for very subtle changes. And that can be really helpful, particularly if you've got a lot of moles to check and it's difficult to know if there's any subtle changes. So that usually is very helpful in picking up things early. The difficulty is that photography for melanoma surveillance is not covered by Medicare at this point in time. and they can be expensive. So there are a few research gaps to try to that need to be looked into in order to address this. There was a submission to the Medical Services Advisory Committee to suggest that melanoma surveillance photography should be put onto Medicare so that our patients are reimbursed. And this has not been approved pending further evidence. So we'll have a trial underway, which I'll explain in a moment, that will help provide the evidence to MSAC of the benefits of melanoma surveillance photography. So we've got a really good opportunity to provide that evidence. This is a trial of melanoma surveillance photography to improve early detection of melanoma in high-risk patients. And that will be run by the Melanoma and Skin Cancer Trials Group and will be opening soon. Unfortunately, we've been hampered a little bit with COVID, but that will soon be open. And if you're interested, you can check out the Melanoma and Skin Cancer Trials Group website. The other opportunity that we have is a really exciting initiative that is funded by the Australian Cancer Research Foundation. And this is to develop the Australian Centre of Excellence for Melanoma Imaging and Diagnosis. And this is a big collaborative effort with colleagues from the University of Queensland and the University of Sydney to roll out 3D imaging infrastructure across the 3 states that will enable us to do these types of research projects and improve early detection and diagnosis of melanoma. So the team members are many and varied. We've got a lot of different backgrounds in the team, and essentially we're wanting to implement these imaging systems in the metropolitan centres, but also in some of the regional centres so that our regional patients can take advantage of this. And telehealth is taking off really with the COVID situation, and people are using that a lot more. It is difficult though to do a skin check via telehealth, and some of you might have had that experience. And so this is an initiative that might help to remedy that as well. And essentially the infrastructure are these Vectra 3D imaging machines that have 92 cameras around them. They can take the images and then stitch them together in a 3D avatar. And then we get extremely good high resolution of individual moles and indeed quite close up into different lesions. And then you can compare the body map side by side to look for changes. And the body map, the computer, the software that comes with this system will also virtually remove all of the moles and put them in a chart for you, and you can arrange them from different sizes to different colours, and then have a look at all the different outliers and see if there are any that are concerning at all. And then you can have a look at images side by side if they're taken, say, 6 months apart or 12 months apart, and there will be some software that will be able to detect changes as well, so that can help us detect if there is anything that we should be paying more attention to. So I think it's really exciting technology. It will help us in the future, and so watch out for the ACEMID project as it goes live next year. So it brings us to whether or not we can in fact have software help us to actually diagnose melanomas. And to date, there have been a number of efforts put towards this. And there are some systems that are becoming available to help us with our diagnosis using artificial intelligence. There was a paper that was published in the journal Nature in 2017, which put everybody into a bit of a spin, particularly dermatologists, because it said that essentially a computer was as good as us at diagnosing lesions. And so this is actually really exciting because it shows us that, at least in test conditions, that the computer is actually getting it right a lot of the time. And you can see there, the blue line is the accuracy of the computer, and you can see the little red dots are all board certified dermatologists in the US. And the sensitivity and specificity of the diagnoses is actually pretty spectacular. So it's really exciting work. There is a lot of work going into this from many different groups, and I think it's a matter of time before artificial intelligence for diagnosis is integrated into what we do. There's been a flurry of papers since that initial publication, and we're really excited to be contributing in that field as well. There are a few things that are difficult about the way AI has been developed to date. So many data sets that include lots of different moles are very varied, with only a couple of lesions from one patient. Some of them will have histological confirmation, so pathology confirmation, and others won't. So with the ACEMID project, with the infrastructure that we'll be able to really have a look at all of the moles from any individual, and it will be much more representative. And we're hoping that that will improve the accuracy again to the next level, to be able to integrate artificial intelligence into our diagnostics and improve early detection for all of our patients. We are looking at integrating this into the clinic, this sort of technology into the clinic already. And we've been running a trial with the Melanoma and Skin Cancer Trials group called SMARTY, which is use of artificial intelligence algorithm that was developed by Monash University and together with MoleMap, the company, to integrate the artificial intelligence system into an imaging device, a camera that we can use in the clinic very easily. And so this trial is currently recruiting. We're about halfway through, and I think we've got some really exciting results that we'll be able to share hopefully next year with you. So having had a melanoma diagnosed, who really should you be seeing? So certainly if you have any complex melanomas, if you have a thick melanoma or an intermediate thickness melanoma, really it's a good idea to discuss with your doctor being referred to a multidisciplinary team. A lot of in situ melanomas and thinner melanomas can be very safely managed in the community, and we're always here to support GPs and community doctors to be able to do this. But if your situation is more complex, I think being managed in a multidisciplinary team setting is a good idea. We do manage patients together, where you can see a photo of us there having a discussion about each of our patients. We have oncologists, surgeons, radiation oncologists in the room, dermatologists, and our care and our clinic coordinators, and we can really organise the pathway that best suits the individual. We also are tied in, and this goes for all the tertiary centres that have melanoma units, usually very well tied in with research and clinical trials. And so really those opportunities to be involved in research and trials, if you're interested, I think are important. And the research and the trials that we do directly impacts the way that we care for our patients and the opportunities that patients will have in years to come. Is it safe to see my doctor at the moment? Well, it is. We may look a little bit different. There's some really good advice and support that MPA have put together for patients. It's available on their website. This is our clinic coordinator, Marissa, fielding calls from our doctors who are working off-site doing telehealth. So some of us are working off-site, some of us are working on-site, and we're always there to see you face-to-face, obviously, if that's what needs to happen. We obviously try to keep people at home where we can and where it's safe to do that, and offer a telehealth consult, and that's particularly useful if we're talking about results. But oftentimes if we're planning surgery and so on, it's best to see you face to face, and it is safe to do that. So with that, I'll leave with a final slide just to make you aware about a survey that we have worked on together with MPA and a number of other groups, looking at improving melanoma and skin cancer awareness in regional and rural Australia. It will be available soon and may be coming to you via MPA, and I encourage you to have your say and let us know if there are any experiences that you would like to share, and any information that you feel you need or could be delivered in a better way to you. So looking forward to hearing from you. Thanks everybody for your attention.
Thanks, Tori. That was great. I'm just thinking sorry, there's a glitch here. There we go. We're back on track. Sorry about that. So our next guest speaker is Associate Professor David Gyorki. Now, Professor Gyorki is a specialist surgeon in complex surgical oncology, that is, surgery for patients with cancer. He is a consultant surgeon at the Peter MacCallum Cancer Centre, as well as the Olivia Newton-John Cancer Centre. And he has a particular interest in the management of patients with melanoma, soft tissue sarcoma, and breast cancer. After completing his training in general surgery at St Vincent's Hospital here in Melbourne and at the Peter MacCallum Cancer Centre, David was awarded a fellowship of the Royal Australasian College of Surgeons. Following this, he pursued further specialist training in surgical oncology at Memorial Sloan Kettering Cancer Center in New York in America, which is one of the world's foremost cancer centers. David has a strong academic focus and is committed to ensuring that patients receive the most up-to-date treatment. He is a member of the Australian Melanoma Guidelines Working Party, as well as an American Society of Clinical Oncology Melanoma Guidelines Expert Panel. David has published widely in the fields of melanoma, soft tissue sarcoma, and breast cancer. Thank you, David. We're all ready for your presentation. Looking forward to it.
Thank you, Alison, for that very generous introduction. And thanks so much for the invitation to speak to you all today. I've really enjoyed the meeting so far, and this is, I think, the second or third one of these that I've been a part of, and it's really great to be able to discuss what we're up to in this forum. And Tori gave a really nice introduction to melanoma diagnosis, and also highlighted, as Victoria did, the importance of MPA in the role that it has in highlighting to patients what is best standard of care, and also highlighting to us as the clinicians the patient's focus, although obviously that drives a lot of what we do. So the overview of what I'm going to talk about is the role of surgery. First, I'll talk about surgery for primary melanoma, which Tori's already touched on a little, but I'll expand on that. Both the treatment of the melanoma itself, but also lymph node surgery, where the main role is to treat the melanoma with minimal morbidity, but also optimize patient risk assessment. The other aspect that I'll talk about towards the end of the talk in less detail is surgery for advanced melanoma. And throughout all of this, Tori's already touched on this, but I will go over and over and over again about the importance of the multidisciplinary team, because essentially the key to achieving optimal outcomes is to having input from a diverse range of experts in the field. So melanoma is a big problem in Australia. There's about 16,000 patients diagnosed with melanoma in 2020 and about 1,400 deaths. The good news is that for the first time we're seeing that number of deaths starting to come down, and that's largely as a result of the implementation of successful systemic therapies, which I'll touch on but will be discussed in more detail in the future talks in this series, which I would encourage you to join into. The key point here, though, is that most patients with melanoma are cured of their disease, and the treatment modality that is most successful for most of those patients is surgery. So most patients with melanoma will never see or never require any drug treatment and will be cured of their disease with an operation. And what I've shown here is the survival curves according to patients' stage. So for those of you unfamiliar with the concept of staging, so staging is something that's applied in all different cancers, and it's where we use characteristics of a patient's cancer to provide risk stratification. For different cancers, we have different aspects of the tumor that we use. In melanoma, the main 2 points that we look at are the Breslow thickness, which is the number of millimeters that a melanoma penetrates into the skin, and whether or not the melanoma has ulceration on the surface. So when a patient sees a GP or a dermatologist and they think this lesion could be melanoma, and as Tori described, the lesion gets cut out, that gets sent for pathology, the pathology report comes back, and the two main features that we look for are the Breslow thickness and the ulceration. What you'll notice is not shown on this slide, but I will highlight because it is a source of confusion, is something called the Clark level. And for those of you who might have had melanoma in the past, you might have had highlighted to you that you had a level 3 or a level 4 melanoma. That could be quite a confusing aspect of the pathology report, because level 3 and level 4 sounds a lot like stage 3 and stage 4, which are completely different. So level 3 and level 4 talks about how many layers of skin the melanoma has penetrated. And while there is some impact of the level on the outcome, it's much less significant than the thickness. And so we generally don't worry about the level. And I'll talk about what the staging actually means. But I would encourage any of you who have had your doctors tell you about the level of your melanoma and that level is bad, to just ignore that piece of information because it's not particularly helpful. So the extent of the primary melanoma generally guides the amount of surgery that a patient needs. So this is a patient who I saw in the clinic about 10 years ago, who'd had his surgery about 20 years before that. And in the past, there was a dogma that melanomas needed to be excised with a very wide margin. So he would have had a 5 centimeter margin with 5 centimeters of normal skin removed all the way around the melanoma. What you'll also notice is that he has a big swollen arm on the left side, and that's because he would have had all of the lymph nodes removed on the left side. That sort of surgery is not really done at all anymore, but it's a really good portrayal of where melanoma surgery used to be in the past. So the aim here is to widely excise the primary tumor with an adequate margin of normal tissue to minimize the risk of local recurrence. And for a long time now, we've been debating over what exactly is the definition of an adequate margin of normal tissue. So this is what the current Australian guidelines say. So for an in situ or a precancerous melanoma, the recommended margin is 0.5 centimetre. For a melanoma less than 1 millimetre, it's a 1 centimetre margin. For a melanoma of 1 to 2 millimetres, it's somewhere between a 1 to 2 centimetre margin. And when it's more than 2 millimetres thick, we recommend a 2 centimetre margin. So that's 2 centimetres of normal skin all the way around the melanoma. You can see here what the difference is between a 1 centimetre margin. So this is a melanoma. There's the scar from the original excision. We've added 1 centimetre around it, and that is the skin within that ellipse that will be excised. In most cases, when you take out 1 centimetre of skin, you can just close the two edges together and end up with a straight scar. In this case, the scale is obviously different, so it's a little bit deceptive putting them next to each other. But this extent of surgery, which is 2 centimetres on either side of the scar, will leave a 4 centimetre defect, and often that is not able to be closed primarily, and so this patient needs a flap to close the wound. And so we have asked the question, as have many others, whether patients really need a 2 centimetre margin. And again, I'll highlight the great work that the Melanoma and Skin Cancer Trials Group's doing, and Tori, in her role on the executive of that, or the board of that, is critical in the success of mask. Basically, we are running an international trial to try and see whether or not a 1 centimetre margin is adequate for all melanomas. So this is a trial that was open. We were successful in getting funding from the NHMRC, and we're running a trial of hoping to recruit 3,000 patients from around the world over the next 5 years. And hopefully in about a decade from now, when we get the answers, we will show that a 1 centimetre margin is adequate and the 2 centimetre margin is no longer required. But for now, patients still are treated according to the guidelines. But if you do have a new melanoma and you do come to one of the recruiting centres, it's quite possible that this study will be discussed with you, where we're randomising patients according to a computer to either 1 or a 2 centimetre margin to provide the evidence that we're looking for. The next important thing to talk about is sentinel lymph node biopsy. So what is this procedure? Basically, skin all over your body drains to lymph nodes. What do lymph nodes do? Lymph nodes look after that part of your skin. If an organism or a bacteria gets in through the skin, the lymph node is where your immune system sees that that organism and fights it. But in the same way, if a melanoma starts to grow on the skin, when it starts to spread, often the first place that it'll spread to is to lymph nodes. And we have a test where we can find which lymph node looks after the piece of skin where the melanoma arises. And we can take that lymph node out, give it to the pathologist so that they can look at it under the microscope and tell us if there's any cancer in it. That's a sentinel lymph node biopsy. We use a procedure called a lymphoscintigram, which is a nuclear medicine procedure to find the lymph node. So you can see here, this patient had a melanoma on their neck that was injected with a tracer, and that tracer has gone to 2 separate lymph nodes, one up here in the top of the neck, one down here in the bottom of the neck. These are the 2 sentinel nodes. So this scan doesn't tell us if there's cancer in it. It just tells us which lymph nodes we need to take out to give to the pathologist for them to tell us if there's any melanoma in it. And here's the procedure of removing the lymph node. You can see we've used both that probe, the gamma probe, but also we used some blue dye. This is a different patient. The melanoma is on the scalp up here. You can see the hole from where we've cut out that margin. And you can see here a small cut to find the lymph node which has the blue dye in it, which we'll take out and send to pathology. So why do we do this procedure and who should have it? Well, the reason we do it is because whether or not there's melanoma in the node is the most important predictor of how the patients will go from the point of view of the risk of recurrence and of dying from melanoma. And the risk of the node being involved varies depending on the patient tumor factors that we talked about earlier, that is the Breslow thickness and the presence or absence of ulceration. And so undergoing sentinel node biopsy itself does not necessarily increase the survival of patients, but this is not necessarily surprising because many patients who have a sentinel node biopsy don't actually have any cancer in their node. So they're not actually going to be able to have a survival benefit from removing the lymph node. But what they do get is the reassurance that their melanoma is of a lower risk. So if I've put here a patient example. This is a 50-year-old man who has a lesion excised from his arm, which shows a 1.8 millimeter ulcerated melanoma. So this is a intermediate thickness melanoma, and he has approximately a 20% risk of lymph node involvement. So if this patient's lymph node is negative, that's an 80% chance. He would have a stage 2A melanoma with a reasonably good survival. By contrast, if the lymph node is positive, it's a stage 3 melanoma, still has a much better than even chance of not dying from their melanoma, but the risk of dying is about double. And so patients in this group would be in the current era recommended drug treatment and certainly recommended closer surveillance. And I'll get to those 2 points in a minute. So this is, we talked earlier about staging. So this is the staging table where we look here across the top at the primary tumor, how thick it is from T1, 2, 3, 4, the number of millimeters that the tumor goes into the skin, and whether or not it's ulcerated, which is B, or not ulcerated, A. And you can see that as the thickness goes up, the stage goes up. So this is stage 3A, 3B, and 3C. But then also here you have how many lymph nodes are involved and how big the lymph nodes are involved. So as the number of lymph nodes go up, similarly, sorry, I just stopped my share for some reason, share screen. Sorry about that. As the number of lymph nodes goes up, so does the stage. So you can see here, these are graphs of survival. Patients with stage 3A disease with an early melanoma and one microscopic deposit of melanoma actually have a very good prognosis, but as the thickness of the melanoma goes up and as the number of lymph nodes with melanoma in them go up, the prognosis of the patients becomes worse. So what do we do if the lymph node is positive? Well, in the past, that was an automatic indication for going in and taking out the rest of the lymph nodes. Now, taking out the rest of the lymph nodes is an operation that has quite significant morbidity and side effects. And so a study was done to see whether or not it was okay to just do regular ultrasounds instead of doing surgery, and then doing surgery only if the ultrasound showed that another lymph node was enlarging. And that kind of made sense because the majority of patients with one node found at sentinel lymph node biopsy, sorry, one or two or however many patients found with sentinel node involvement don't have any more lymph nodes with cancer in it. And sure enough, the results of that study showed that there was no benefit to going in immediately to remove the rest of the lymph nodes. And so now if a patient has a positive sentinel node, we routinely put those patients onto a surveillance program where they have regular ultrasounds and scans. And only if that shows other nodes starting to grow would they go on to have further surgery. Because really what benefits patients with lymph node involvement is drug treatment. And you'll hear more about this from the speakers later in the series, but I'll highlight a couple of the seminal papers here. This is a paper where immunotherapy was used, and nivolumab is an immunotherapy agent targeting a molecule called PD-1. And you can see here, when that drug was compared with an older immunotherapy agent, the survival of patients, or the recurrence-free survival, that is the time to their cancer coming back, was significantly improved. And these drugs have reduced the risk of recurrence for patients after surgery for stage 3 melanoma by 1/2, which is a huge improvement in outcome. So a 50% improvement in survival for these patients. And that has dramatically changed our standard of treatment for patients with primary melanoma. This is similarly using a different class of drugs. So you'll hear later in the series that about 1/2 of melanomas have a mutation in a gene called BRAF. And if a melanoma has that mutation, then we can use a different class of drugs to immunotherapy where we target that mutation. And similarly, you can see this improvement in recurrence-free survival and in overall survival, that's that blue line, in patients receiving treatment with the targeted therapy versus placebo or no drug treatment. So you can see that closer this line is to a straight line along a straight horizontal line, the better the outcome for the patients. So what's the downside to a sentinel node biopsy? Well, it is an operation. There is a risk of wound infection, seroma, which is fluid accumulating where the lymph node's removed, or mild lymphedema. There's also a false negative rate. That is, that if the lymph node test comes back saying it's negative, actually there was a small amount of disease that was missed. But we did a study at Peter Mac where we took 100 patients who had had a negative sentinel node biopsy and assessed for their complications and asked them about their experience. And the vast majority of patients strongly were supportive of the treatment. So this is the Australian guidelines, which recommend that patients with sentinel node biopsy should be considered for all patients with melanomas greater than 1 millimeter thick, or for melanomas more than 0.75 millimeters thick with other high-risk pathological features. So what about patients with palpable nodes? That is where the nodes can be felt by the surgeon or the clinician. These patients traditionally are treated with surgery. Well, first they undergo staging where we do scans to make sure there's no other evidence of disease, and then they undergo surgery to remove all of the lymph nodes that can be felt, as well as the other lymph nodes in that nodal basin. These patients would generally be recommended for drug treatment. And more now, we're actually giving the drug treatment before the surgery. And I'm not going to go into that. We call that neoadjuvant therapy. So instead of doing surgery first and drug treatment to follow, we're now starting to give the drug treatment first for a period of about 6 weeks, and then do the surgery afterwards. And there are a number of benefits to doing it that way around. This is a type of disease called in-transit disease. You can see here, this is a patient's leg, and that's where the melanoma was initially found. That's a skin graft, and you can see these spots that have popped up around it. About 5% of patients whose melanoma recurs will recur with this type of disease pattern. And we have a number of options for how to treat this, including surgery if it's limited in volume, including limb infusion where we put the chemotherapy into the leg, including various injections, and more now with drug treatment. And then stage 4 melanoma, which is melanoma that has traveled beyond the lymph nodes to other sites of disease. Sometimes surgery is considered here as well. Obviously, this is dependent on the discussion within our multidisciplinary teams. We don't usually use surgery first in this setting because the drugs are so effective. We usually give drug treatment first. But sometimes after they've received drug treatment, if a particular spot of melanoma won't go away or it just continues to grow, we would consider surgery to remove that area of resistant disease. So in conclusion, surgery is a very important part of the treatment for the majority of patients with melanoma. For most patients, surgery is the only treatment they need and is curative. And large studies have shown that equivalent outcomes can be achieved with less surgery. So whereas previously we used to take very wide margins, we're now taking narrower margins, and hopefully in the coming years we'll be taking even narrower margins. Where we used to take lots of lymph nodes, we're now taking fewer lymph nodes to try to make the surgical impact on patients' outcomes as minimal as possible. Thank you very much.
Thanks, David. That was a great presentation. My gosh, haven't we come a long way since 30 or 40 years ago. So I'd like to ask, we've got David still on the screen. If I could have Tori back and Victoria Beadle, our CEO. And I've been monitoring the questions that you've been sending in. And I know some people had some questions before tonight that I thought I would just ask as well. So one question that's come up is someone has asked, is mucosal melanoma surgery conducted differently to cutaneous melanoma? That'd be for you, David.
I might take that one. Yes. So,
yes.
So mucosal melanoma can occur in a number of different parts of the body. The common areas where we find mucosal melanoma are in the head and neck, so in the nose and sinuses, in the lower part of the gastrointestinal tract, so in the anal area, and then in gynecological areas. They are treated very differently from cutaneous melanoma, and it's really a completely different disease. And so, you know, when we talk about melanoma, unfortunately, we usually are talking about cutaneous melanoma, and mucosal melanoma is actually an underrepresented part of melanoma research. It's underrepresented in melanoma treatment, and the success rates are actually not as good. But I know that it's an area of increasing interest, or it's of interest to MPA and also to MAS to try and improve outcomes for patients with mucosal melanoma. But yes, surgery for a lot of patients is the primary treatment modality if it has not spread.
Okay. Tori, a question for you, I think. How does accumulated sun damage increase the incidence of melanoma? Because we know, I'll let you go.
No, it's a good question. So I think there are sort of two pathways to developing melanoma. There are some people who develop melanoma when they're younger, and they tend to be probably a bit more genetically predisposed. They tend to be people with high risk, what we call phenotype. So lots of moles, maybe red hair, freckling, those sorts of things. And then there is another group of people that develop melanoma through a slightly different pathway, through cumulative UV damage over many, many years, and they develop melanoma when they're older. And so what happens with UV is that it goes into the cells in the skin and it disrupts the DNA, and it essentially breaks the DNA up, and the DNA will try to repair itself, and sometimes it's effective in doing that and other times it's not. And when you get lots of different changes to your DNA, you can get a mutation that then is essentially carcinogenic. So it will drive a melanoma to develop, and then that, you know, that's when you run into trouble. So we see people with a lot of DNA damage developing all sorts of skin cancers later in life. So it's the same for squamous cell and basal cell cancers as well. You can accumulate those with age too, but also yes, specifically with melanoma. And the younger people who develop melanoma at a younger age probably require less of that UV damage to develop their melanoma. So it's slightly different.
Okay, thank you. Another question that would be for both David and Tori, is gene testing. So, you know, someone's, actually a couple of people have asked, if there's a strong family history, do I need to be tested for any genes that, you know, that might run in my family that's making me get melanoma? I mean, making me get melanoma, but developing a melanoma. Does it run in families? Can you inherit a gene?
So you can. There are high-risk genes that actually occur fairly uncommonly in the general population. So fewer than 0.1% of the general population will carry a melanoma risk gene. But if you have a strong family history, and that we define as 3 or more close relatives, so as if, you know, a number of people in your close immediate family that need to have had melanoma to qualify for a strong family history. And then there are other features that we look for too. So people who have developed melanoma at a younger age are a little bit more likely to carry a melanoma risk gene. And people where there's other cancers in the family, for instance, pancreatic cancer, or if there are people that have had multiple melanomas as well. So they're all things that make us think that perhaps genetic testing might be a good idea.
Okay, and
I'll
just on that
to that.
Sorry, go on, David.
I'll just add to that, that even, so Tori's absolutely right that we have a pretty high threshold for doing gene testing, because even those patients where we do have gene testing identified, there's not a huge amount that we would do with that information. But that doesn't mean that we don't care about a family history just because we don't send patients for gene testing. So the most common reason why someone will have a family history of melanoma and then have melanoma themselves is because they have the same skin type. And so you haven't actually inherited a specific mutation, but you look like your parents and you have red hair and blue eyes like your parents, and they got melanoma because they saw a lot of sun. And so you're going to get melanoma because you've seen a lot of sun. And so, you know, in Tori's presentation, you had the frequency of follow-up based on risk, and risk has a lot of components, and family history and skin type are two critical ones there.
Okay, thank you. Another question is, when should I start getting my children? The question is, I've stage 3 patient. When should my children are young, they're under 10. When should I start getting them to have skin checks?
Yeah, so it's a really good question, and I get this question a lot. It's a really nerve-wracking thing, I think, as a parent to go through a cancer diagnosis, and of course you worry about your children and any risk that you might have passed on to them as well. Truthfully, melanoma in children is very rare, and so we wouldn't recommend routine skin checks of children, but it's good for anyone to know what's on your skin and to check, and if there's anything that stands out as being unusual, then certainly a good idea to get it checked. But routine skin checks for children isn't really necessary unless there is a specific concern, and we're always happy to discuss what's best for your individual situation. Yep.
Okay, another question that's come through is, I think, David, this might be one for you. I've been to you, 2 questions actually for you. So first one is, I've been to you, I've had my melanoma excised, and but it's come back. It's now spread to my lymph nodes, or it's now spread to one of my organs. And I was told that the margins were clear, and I don't understand why it's come back.
So that's a really good question. And melanoma is a pretty unusual cancer like that, in that it starts off as a very small lesion. You know, it's a small spot on the skin that gets removed. And sometimes, even if the lymph node is negative, it might still come back. And sometimes it can come back many years later. So what's been happening there, and this is actually a particular area of interest of mine. So what's happened is that a microscopic deposit of melanoma has spread somewhere else in the body and has been sitting there dormant, being kept under control, probably by the patient's immune system, often for a long time. You know, sometimes for decades, the melanoma can just sit there not doing anything. And so, you know, why does it escape from that immune control? What are the mechanisms driving that? These are all very important questions. But this is the reality of what happens. And we are getting better at treating patients. We are getting better at detecting recurrence early. One of the benefits to doing sentinel node biopsy is to identify high-risk patients who benefit from close follow-up so that we can pick up that recurrence before the patients are aware of their recurrence. I mean, hopefully that answers your question, but we think that it's probably due to a loss of immune control.
Is there anything I can do to improve my, I'm just going on what you've just following on from that. Is there anything I can do to improve my immune system after I've had a melanoma removed? Maybe
Yeah, so
Tori, David?
Tori, you want to have a go?
Which?
Yeah, I mean, I think keeping healthy it generally is a really good idea, and you know, the best thing that you can do is you know, staying fit, having a good diet, and having a good outlook is actually really important. And so there's a lot of support and help that you can reach out for, but I think the usual, you know, stay healthy and active. There's a lot of interest in things like diet and the microbiome and how that might influence our immune system. I think there's a lot of research going on at the moment about that, but it's sort of early days as to, you know, making any specific recommendations about that.
And for the most part, when patients' melanoma comes back, it's not because of anything that they've done. It's usually just bad luck. So yes, while I completely agree with Tori that staying fit and healthy puts you in the best position to get your cancer treated optimally if it does come back, we generally do not have any factors that we identify in patients' activity or lifestyle that would precipitate recurrence.
Okay. So another question I've had is, I've had stage 1 and I had a clear sentinel lymph node biopsy, and everyone I see is having scans, but my doctor has said I don't need them. Why is that? I don't understand. And what's the difference between a PET scan and a CT scan? So there's a double question for you in one.
So look, scans are not a free lunch, I think is the first thing to say. So a scan is not firstly, it's not a perfect, there's no perfect test. And if you have a very low risk of your melanoma recurring and you get a scan, there's a higher chance that that scan is going to cause you harm than benefit. And by harm, I mean that if you put 100 normal healthy patients into PET scanners, then about between 5 and 10 of them will have something identified on the scan. And that something is probably something that would have been there for the rest of their life and never detected. And when we see it on the scan, it means we've got to do something about it because we need to prove that it's not cancer. So that involves possibly doing another scan, possibly doing a biopsy, possibly doing some sort of invasive test that's going to cause them the risk of injury, only to provide them with the reassurance that which we were providing them before they had the scan in the first place. And so I think that's a really important message, that unless you reach a certain threshold where we think that there's a real risk of detecting something on the scan should not be done. So we're quite judicious. There have been a number of studies done looking at the benefits of scanning to detect early recurrence. And you need to have a certain number of patients where you know they're going to recur before there's any benefit to doing routine scanning.
Okay, thank you.
Or do you want to add anything to that?
you can continue as much as you want, David.
No, I think that was a very good answer. I
Oh,
think.
I thought you meant me. I didn't
Oh,
realize.
sorry.
Sorry.
No, it's always a risk benefit, and you always have to think about what the pre-test probability is of actually detecting something that is cancer. And you need to, I think, understand that before any scan or any test that you have. So, yeah.
I spend a lot of my life telling patients who have had scans that actually, even though there's something there, I don't think that it's anything and it's going to be okay. But it's very hard to provide that reassurance to people because they don't have my experience. They just know that I'm telling them that there's something on their scan. And they're obviously very worried that their cancer has recurred. And it can be extremely difficult to relieve the anxiety that those scans cause. And so it's a hugely important message that scans cause anxiety. Patients who are having routine scans don't need me to tell them that, it's the first thing, when a patient comes in after having had a routine scan, when they felt completely well 3 days ago, they got the scan, then all of a sudden they feel like they're going to vomit because they're waiting to see what the scan shows. And it's not until I tell them the scan's normal that they can rest assured. And if I can't reassure them because there's something on the scan that probably isn't melanoma, but I can't tell them with 100% certainty, then now it's going to be 3 months until they get the next scan to provide them with the reassurance that they would have had they never had the scan in the first place. So there's a lot of harm in scans. So you need to really have benefit before you have to, they've got to be worthwhile doing before you order them.
So what's the difference between a PET scan and a CT scan? And patients I have a number of people who've told me that they're going to go and see their GP to get a scan ordered. And some people say, I'm going to definitely have a PET, and others say, I want a CT, and they've had stage 1 melanoma, so a thinnish or intermediate melanoma.
So PET scan, I'm going to take these out because I'm going to PET scans are a scan where patients are injected with, usually it's an FDG PET scan, so they get injected with radioactive glucose, which is preferentially taken up by melanoma cells. And so if you have a deposit of melanoma that's of a certain size, so it won't pick up with 100% certainty, so you can have melanoma and have a negative PET scan, but it is for patients with reasonably sized deposits of spread, an accurate test to pick up spread. By contrast, CT scan is just a pure anatomic scan, so they don't inject anything radioactive, it just maps the anatomy of the patient, and it can then detect deposits of tumour that shouldn't be there, or enlarged lymph nodes that shouldn't be there, or spots in the lung or liver, or those sorts of things. But no scan is perfect.
David, we've got another question. I have mucosal melanoma. I had a PET/CT scan which came up clear, and 9 days later a malignant mucosal melanoma was found in my cheek.
Sorry, should I have heard that? I missed part of that question, Victoria. So, Tori, have you got it?
So I suppose in part to answer that, PET scans can detect things usually greater than 5 millimeters. So oftentimes if you had a PET before your melanoma, your primary melanoma was removed, oftentimes a PET scan would never have actually seen that primary melanoma in the skin. So it will only detect things that are over about 5 millimeters in diameter. So as David says, it's not perfect. It won't detect everything. Sometimes tumours can grow rapidly, and this is the other issue with scans is that you can develop disease in the interval between scans.
Having said that, we have looked at Peter Mac in our stage 3 patients who we do regular scans for. And actually, if you have stage 3 melanoma and you're having routine surveillance scans, then it's extremely unusual or unlikely for you to present with symptomatic recurrence if you've had a normal scan. So it's possible. So we usually do scans every 6 months for stage 3 patients. and it's possible, obviously, that your next scan will show something if your previous scan didn't show anything, but it's very unlikely that you're going to present with a problem between your scans. That is a disease that grows very rapidly and makes you sick. So that's why, we have a very clearly mapped out surveillance protocol, because in those patients where the scans have a reasonably high risk of detecting recurrence, it can be very reassuring if it's negative.
Thanks. I have another question that regularly comes up, and it's about vitamin D levels. Now, I know in Melbourne, there's the UV index is really low, but in the other states, and we have people from all over Australia here tonight, I'm wondering how important are those levels? And when I use sun cream, am I still receiving vitamin D? And do I need to take vitamin D supplements?
Yeah, so your vitamin D levels will fluctuate naturally through the year. So in winter, they'll be naturally a little bit lower than in summer. You will get enough UV to help promote vitamin D production if you're wearing sunscreen through summer. So we still recommend that you do apply sunscreen. Sunscreen, even 30 or 50 plus, will let through some UV. And even getting half an hour's exercise during the day will allow you to get enough the vitamin D that you need. So if you have seen your doctor and they're worried about you having, very low vitamin D, then it's worthwhile considering and talking to them about having supplements, but we don't recommend it across the board.
Okay.
The other thing I say to patients with melanoma is that you don't necessarily need to be a hermit and stay out of the sun completely. So there are now a lot of really good UV apps that are available on your phone, and particularly in the summer months, you can see the UV peak and trough. And as long as the UV index is below 5, there's no great harm in being outside. And so obviously, depending on the time of the year, it gets to 5 earlier in the day and below 5 later in the day in the peak of summer. But if you're aware of where the UV index is, then you can mitigate your risk. There's a lot of truth in the 11 to 3 sit under a tree dogma.
Okay. The other question that's come along is, and I guess this is particular, it must be from someone from Melbourne. I'm worried about a worrying spot on my arm, but the earliest my dermatologist can book me in is in 2 weeks. Is this okay? Because my GP's only doing telehealth consults.
Yeah, so it's difficult at the moment in Melbourne. I completely understand that. A lot of doctors are just doing telehealth consults, and of course it's difficult to properly assess lesions via telehealth, although you can send photographs in, and sometimes we can reassure you quite well with photographs, but not always. So it is preferable to go face to face. And 2 weeks is fine. Sometimes if you're very worried and you would like an urgent appointment, most dermatologists will have urgent appointments put aside for people who are concerned about a melanoma, and your GP just needs to give them a call and say that it's an urgent booking and the suspicion is melanoma. And we'll usually be able to get you in quickly. I know we have certain appointments put aside for that. And if you're already known to a dermatologist, often you can call and ask just for a spot check, and you can be slotted in quickly. So having said that, 2 weeks is a fine amount of time to wait if you can.
Okay. And I'll just say this is the last call for questions, but this one is for David, and someone's asked about, they're coming back to you. They've had their clear sentinel lymph node biopsy, but they're coming back to you just regular checkups. Are there any blood tests that they should be having?
No, I don't ordinarily do routine blood tests for low risk melanoma patients. In fact, I don't do routine blood tests for high risk melanoma patients. There is, we're doing some research in various blood tests that might be useful, not necessarily in stage 1 patients, but in patients at a higher risk, to try and pick up recurrence earlier than scans. But we don't have any routine blood tests that we would do for patients who have had curative intent treatment for melanoma.
Okay, well, thank you. All right, well, it's time to close now, and I thank everyone for the great questions and for coming along tonight, and of course to our 2 special guest speakers. I hope you found it enjoyable and informative. There was lots of information given out tonight, and of course, as I said it earlier, in a week or 2 we'll have the webinar up on our website, so you can have another look there if you missed something tonight. I also would like to remind you, now I'm just going to share this to see if it works. So it may or may not. Anyway, we'll see. I'm not as snazzy as the other ones. Here we go. So this is, remember, this is our first webinar of a 4-part series. And at our next webinar, number 2, will be at the end of September. And we'll have guest speakers talking about fear of recurrence, fear of progression, survivorship, and oncology dietetics and oncology exercise physiologists. Now, because you've already registered tonight, we'll be sending you a link automatically for that one too. So, and you can choose to attend or not. And I just know you all will. So I think that wraps it up for the night. And thank you, everyone. Take care. Good night.